Start recording. Welcome everyone to the What the F, the White Dress Project's research forum on fibroids. My name is Tanya Leek and I am co-director of the White Dress Project Research Committee with my partner. You want to introduce yourself?
Hi, I'm Dr. Rochelle Wolf, and yes, also the co-director of research for the White Dress Project with the wonderful Tanya Leek. We are super excited about a topic that's somewhat near and dear to my heart. My background is I'm an interventional radiologist and love, women's health. And we have the great opportunity to have a fabulous interventional radiologist who I truly respect. She's brilliant, joining in on the discussion and kind of leading what's the latest and greatest that you should know about uterine fibroid embolization. And as always, we have our fabulous patient advocate who has a really compelling story that we'll also get to tonight. So we're really excited about this, and we'll be recording, but throughout the evening tonight, just feel free to ask questions along the way.
Yes. We do have a special sort of introduction and then we're going to open it up. But we do encourage you now to go ahead and in the chat, if you want to mention kind of what made you want to attend this session, so we have some understanding, so maybe we can touch on some of the things as we work through the intro. That would be helpful. So who you are, what's your interest in UFE, already had it, thinking about having it, scheduled to have it, whatever your status might be. And with that, we're gonna get rolling. So just as a quick introduction, let me make sure that I wanna make sure, do you see the presentation? Yes?
Yes.
Okay. All right. So as we mentioned, what the F, we have to mention, this is our commercial. Next month is Fibroid Awareness Month. And so we celebrate Fibroid Awareness Month with our signature event, the Empowerment Experience, which is, again, 3 days, hopefully to inspire you, support you, and provide you with information and resources for those who have fibroids. But we encourage every person who is at risk of fibroids. So if you were born with and still preserve your uterus, then you are, this is for you. It's important to share your story, even if you are fibroid free at this point. So that's the Empowerment Experience coming up in July. Registration is still open. It's July 14th through the 16th, and it will take place in DC. So we hope we'll see some of you in person there. In terms of this June session, our June session is fact versus fiction. So you will, hopefully we'll dispel some myths today about the uterine fibroid embolization treatment for fibroids. And again, please ask questions. Please let us know what you want to know. And we hope to bring you up to speed on the latest and greatest, because the information is always changing as research is done and new information is found. So the way that this always goes is we'll do a couple introductions of our guests in more detail. We'll introduce the topic, and then we will open it up. As we said, we really believe that stories are such an important part of the information that we can all share more often. I am going to kind of let the experts, my partner, Dr. Wolf, and Dr. Caridi, and then Bianca, who's actually experienced this treatment. I'm a myomectomy girl. I'm going to let them take it away, and we'll let the experts and the specialists talk about it. So you've been introduced to us. We are your hosts for today. And Dr. Wolf, would you like to introduce our guests?
Unmute myself and then do the introduction. So yes, we are very lucky to have with us two incredible guests. The first is Dr. Theresa Caridi. She, MD, she's a clinical associate professor of interventional radiology at the University of Alabama at Birmingham and medical director for Varian Interventional Solutions. It's a Siemens healthcare company. As a result of her long-standing dedication to the study of women's health interventions and advocacy for women's health patients, she holds a secondary appointment in the Department of Obstetrics and Gynecology at UAB. And I just want to point out that's a very unique thing to have, a dual appointment as an interventional radiologist and also under women's health. So that is incredible. She attended her training at the University of Florida for medical school, and then was actually did her residency at the University of Pennsylvania, and then spent the first 7 years of her career at Georgetown in Washington, D.C. She's also stood in some leadership roles within our main Society of Interventional Radiology, and is just quite an accomplished author, clinician, and just overall great human being. So the next introduction we have is our patient advocate, Bianca Ingram. She is known, her other name is Bianca Gasse, but her stage name is Bianca Ingram. She is a very talented singer, entertainer, creator, and digital brand strategist with a passion for music and a creative spirit. Bianca has made a name for herself in the entertainment industry. In addition to her professional pursuits, Bianca is a devoted mother to her two beautiful children, a 3-year-old son and a 9-month-old daughter. Her journey into motherhood, however, has brought immense joy and aspiration to her life, influencing her artistry and shaping her perspective. Her journey to motherhood has not been quite a straight path, and so I don't want to take that thunder from her. She's had a lot of experience around uterine fibroids and how it's affected her childbirth that she will talk about, and I think it's a very, very important discussion. But through all this, Bianca's resilience and unwavering spirit has been just an inspiration. She uses her personal experiences as fuel for her creative endeavors, influencing her music, performances, and online presence with a real authenticity and relatability. She has created multiple spaces for women to thrive in a safe place, such as Amazonian Nights and motherhood, fitness, and nutrition. So again, an incredibly accomplished woman who's super inspirational to everyone out there dealing with these fibroids and how it actually affected her motherhood. So with that, we also, as everybody, if anyone's ever attended one of these before, we always have our What the F TOTM, which stands for our term of the month. And so tonight, it's just uterine fibroid embolization. And kind of in a nutshell, what is that? It is a minimally invasive, non-surgical procedure that essentially just blocks the blood flow to uterine fibroids. As a result, the fibroids, what I say, quote unquote, dies or decreases in size, and symptoms improve and or resolve in most patients. So it's a very effective procedure. It's been around for over 20 years, yet the awareness around this procedure really needs to gain people just talking about it. So again, this forum creates a great opportunity for people to learn and then share what they've learned. So next slide. So kind of the topic again, how do I know if what I hear about UFE is fact or fiction? So I'm going to let Dr. Caridi take this over and kind of talk about fact versus fiction. It's an incredible, incredible talk.
Oh, wow. Well, thank you so much, first of all, for the warm introduction. I wish we were all in the same room, and having an ability to be a little bit more personal. Thanks for sharing the things in the chat already. It's wonderful to have so many people here who've been affected by fibroids, and I hope that we can help educate about uterine fibroid embolization and other things. What's most important to know, and I'm going to start with this and end with this, is everyone has options, and sometimes, and you should have many options, and this might not be the right one for you or the best one for you. So that's not the purpose of tonight. The purpose of tonight is to educate about this, but to know that if you're in the scenario where someone's telling you there is only one thing, as Dr. Wolf always says, that's not the right place to be, because there are many, many options. So the things that come up a lot about uterine fibroid embolization that you read about on the internet are that certain locations mean you can't have a UFE. Then you'll read that if you have large fibroids or a large uterus from fibroids, that you can't have a UFE. And then the last one that comes up frequently, although there are many other ones, is that if you desire future fertility, that you can't have a UFE. You'll hear me interchangeably say UFE and UAE. That's just uterine artery embolization or uterine fibroid embolization. Uterine artery embolization can be used for a whole host of things, other disease processes other than fibroids. So it's more of a global term, and fibroids, UFE is more specific. Next slide. I don't really have to tell you all what the significance is. I think you're living the significance day to day, but just to give you kind of a global idea of how many women this affects and the prevalence. It's the most common pelvic tumor in women, and it is a tumor, although almost entirely benign. There are really rare instances where there are malignant fibroids, but I don't even want to put your mind on that space. Just to be accurate, I mention it. But 70% of Caucasian women and 80% of African-American women are affected by the age of 50. Now, not all of those women are symptomatic, so about half of those women are symptomatic. But that's a gigantic amount of women. It still remains the most common indication for removing the uterus or performing a hysterectomy in the United States. We're going to return to that big picture that you saw on the right of the screen that is maybe not so appetizing, but I'm going to talk to you about it as we go on because it's a reality for some women. All right. So some of the facts that we can start off with, in which most people agree upon, and they're not even controversial. Uterine fibroid embolization is a global treatment, meaning we don't go in there and treat one fibroid. We're not targeting just one fibroid. We're getting all the fibroids at the same time. It's actually impossible for us to really go after an individual fibroid unless you just happen to have one. But what we're treating is everything that's sucking up all the blood flow. And so that is the case for all the fibroids. So it's a global treatment. And that's where it has similarities to hysterectomy, because just like hysterectomy, you're getting everything at once, even though we're not removing anything. The way that it's similar to myomectomy is that it's uterine sparing. So we're leaving the uterus behind, of course. We're leaving everything behind. We're just shrinking it and making those fibroids non-functional. It's very efficacious, meaning it works for most women. And in fact, it works about 90% of the time, or about for 90% of the women who have this procedure. That means there is a failure rate. And there's also, even with actually hysterectomy, there are some women who have pelvic pain and continue to go on to have pelvic pain because sometimes it's not the cause of the pelvic pain to begin with. And so not everything is 100% efficacious, and really nothing is. There's a short recovery time, certainly less than hysterectomy and myomectomy, because those are surgical procedures. Sometimes the recovery time is de-emphasized, and I'll talk about that at the end as well. Some of the controversies, I already brought them up in some of the questions that we asked before, but I'd like to just take some moments here tonight to talk about what's fiction and give you the actual facts. And those include fibroid location, fibroid size, fertility, and pain. And some of these things about UFE are good and some are not good. And so we're going to talk about all of those. Next slide. Starting with location, so type. And again, I see you all typing in the chat. You all know this probably better than I do at this point. But fibroids can be in a variety of different locations. And even when you hear you have X fibroid in that location could be different than Y fibroid in that location. So it's not, the language is good, but it's not perfect. And so you can see here, let me give you an example. So see where this one says subserosal fibroid along the right side. But then if you look at the opposite side on the left of screen, it says pedunculated subserosal fibroid. Those are very, very different. One is still somewhat contained, but on the outside of the uterus, and one is on a little stalk, right? So they're very, very different. And most women have all of these fibroids, or fibroids even, they may have a dominant fibroid in one location, but most women have a lot of fibroids in a lot of locations, and everyone's just different. Next slide. The way that we define these academically and for imaging purposes is actually by what's called the FIGO or FIGO, it's said both ways, classification. I know this is a lot of information on this slide, but I wanted you to know that we do get more specific in imaging. So you may see this in an imaging report. And if you look, there's these 0, 1s, and 2s. Those are ones that have some kind of contact with the endometrial canal. And that endometrial canal is where a baby is grown and also where your lining sheds monthly with your menstrual cycle. So those are termed submucosal. But again, a 0 and a 2 are very different fibroids, but they're in that general category of submucosal. If you look on the outside of the uterus, those 5, 6, 7s, again, subserosal, but that 7 is on that stalk, right? So very, very different type of fibroid. And that's why when you go to see a specialist, and particularly with what an interventional radiologist can bring to the table, we look at all these characteristics on MRI and we decide, even things we can't pick up on other types of imaging, we can look at exactly the location and what their risks are based on those locations. Next slide. So here's one of the myths and also one of the truths. So this is a submucosal fibroid. Remember those 0, 1s, and 2s that have some kind of contact with the endometrium. And I know I went to like 15 years of school to learn how to read these MRIs. So I don't put those pictures up for the reason that I want you to, or expect you to be able to look at the detail of these, but you can actually catch a fibroid, and this is real, a fibroid can attempt to pass, and those submucosal fibroids are the risky ones. So imagine this. I always talk about fibroids like fruit because I can't think of a better analogy. They're not, but just for a picture in your head, imagine a grapefruit. And if I take away its nutrients and oxygen and it becomes a prune, okay? If that prune is sitting kind of a little bit attached by a little stalk inside the endometrial canal and I make it a prune and it kind of dehydrates and shrivels, it's much more likely to kind of try to pass itself, right? Detach from its tissue. If, however, that grapefruit was initially surrounded by a bunch of muscle, and what we call intramural fibroid, or even on the outside of the uterus, but well attached. Then when we treat it and it becomes that prune, it still has that integrity around it to kind of keep it in its place in most circumstances. So that's why fibroid passage is something we talk about specific mostly to submucosal fibroids. They're the ones that already have a relationship with the endometrial canal, so they can slide into it. And that's a good way to think about it. That being said, again, there's difference between the 0, which is already in the cavity, versus the 1 and the 2. And so this patient had a very large submucosal fibroid that was actually caught on MRI because of symptoms she was having, and it was attempting to pass. This happens extremely rarely. And when a woman comes to see me and she wants to move forward with UFE, even though she has a submucosal fibroid, size is important to discuss and a plan of action. And sometimes that involves a collaborative treatment where she might get her UFE, but she might also get a myomectomy from gynecology. Why would you do that? The reason is because if gynecology goes in to try to resect this submucosal fibroid via a myomectomy and leave the uterus behind, they cannot get all of this tissue because they get fluid imbalances in the procedure and a lot of details that we don't have time to talk about tonight. But the point being, sometimes myomectomy can't do it all, and sometimes UFE can't do it all, and sometimes you need a collaborative treatment. So that's going to be a theme that comes up tonight. All right, next slide. Please feel free to interrupt if you're not with me. There's a lot of data on these slides, but that's just to show you that this is data-driven, and all of this is based on the facts that we know. And that way you can also have these available to you. But I'll try to keep it not too academic driven in the conversation anyway. So please interrupt if you need to. The next location that gets into the controversial area is pedunculated subserosal fibroids. Those are those ones that are attached on the outside of the uterus and they're attached by a narrow stalk. And these pictures, I think, demonstrate it really well. There are case reports of what's called torsion, meaning a twisting of the fibroid, and actually the fibroid becoming infected because of that twist and lack of blood supply. What's interesting is that happens when fibroids, it's been documented with fibroids that have not actually been treated by UFE. And that happens with the ovaries, without any kind of fibroid or mass related to it. Ovaries can torse, testicles can torse. This is a phenomenon that can happen with something on a stalk. So my view, whereas submucosal fibroids that we just talked about, I very much believe, although rarely, fibroids can attempt to pass and there are high-risk fibroids. When it comes to pedunculated subserosal, these ones on the outside on a stalk, I put this into, has it happened? Yes. Are there case reports of it? Yes. But is it because of the fibroid embolization, or is it because they were already at a risk of torsing to begin with or having torsion? And this was a paper that looked at about 66 of these very high-risk fibroids on a narrow stalk. And they followed these patients for a year, and none of them had this phenomenon. So this is the best data that we have. It's not, it's not a randomized controlled trial like the best evidence that we can get, but it's pretty informative. And it puts me at ease about doing these embolizations. I still tell patients when they have this type of fibroid, hey, you could get torsion of this fibroid if it's left behind, whether I treat it or not. So it's something to consider in your process of deciding what type of procedure you want for your fibroids. Next slide. Now let's get to size. I showed you this kind of graphic picture earlier, and I did that because this is the reality for some women. So this, you can see that little ruler next to it. You can't see the details of it, but just so you know, this was a 39-year-old woman, I believe, came into my office in DC, and she was a thin woman who looked completely 9 months pregnant. This is her uterus. If you look at that really big soccer ball, that's all fibroids. That's a conglomeration of fibroids. That smaller part to the left by the ruler, that's her uterus filled with some other fibroids. But this thing was just a mass emanating, a gigantic fibroid mass emanating off of her uterus. And she looked 9 months pregnant. So what did we do for her? We did a fibroid embolization the same day that she went and then had surgery. So why did we do that? She was a woman who didn't accept blood products, and it doesn't have to be this scenario, but that was her particular scenario. And the gynecologist was very worried about the amount of blood loss that might happen in a surgery of this nature. All of those fibroids are filled with blood at the time of surgery if an embolization is not done beforehand. We can actually, like I said, do this same day so that a woman doesn't have to recover separately from two procedures. And so and it can also be done within days or weeks of the uterine fibroid embolization as well. So she opted for a hysterectomy, but with a combined uterine fibroid embolization first. The key about size is not that there's a size limit in what fibroid embolization can do. It's setting the appropriate goals and expectations. So if a woman comes to me and says, I cosmetically don't like my protruding abdomen, and that is the only symptom she has, is just cosmetic, I let her know that my fibroid embolization, depending on where the fibroid is, might only reduce the size of that fibroid by 40 to 60%. Again, it depends on location and size to begin with. But if someone comes and they have bulk symptoms, they've got pressure on their bladder, they have constipation, they've got pelvic pressure, those kinds of things, often a 40 to 60% reduction feels amazing to a woman. And actually they will come back and think everything's gone. But cosmetically, if that's the only symptom or the only sign, this may not be the right procedure, particularly if someone has a size like what you see over on this image. And again, it's important with size to talk about all these things and then potentially consider a combination treatment. So hopefully you can find someone that will work alongside gynecology if needed. Next slide. This is her MRI images. And just to give you a little bit of an idea, I show you these because the organs or the fibroid mass takes up her entire abdomen. You can't see any of her organs. You can see her spine on that left image, but that's basically it. Everything else is fibroid. On the right-sided image, the fibroid is all the stuff on the top of the image. And all the other things you see are the things that are way up almost by the rib cage. So the kidneys and the liver and things like that. This thing was pressing on her vessels. I mean, it was just absolutely gigantic. Next slide. So one of the subjects that comes up all the time. So we've talked about location, we've talked about size. Now we're going to talk about fertility. Again, I put these articles up there so you can reference them if you want. For the longest time, these were the only two articles, and they're from around 2010, a little before, a little after. these were the only articles we had where women entered a study and were compared to uterine preserving techniques. So myomectomy, which preserves the uterus, and UAE. Or the other article was laparoscopic uterine artery occlusion, meaning they clamped basically the uterine arteries, versus uterine fibroid embolization. But either way, 2 articles that allowed women to enroll who wanted future fertility and did something uterine sparing. Okay, so while we have thousands and thousands of women who we looked at data comparing uterine fibroid embolization and hysterectomy, we don't have a lot of information in comparing uterine sparing techniques because women don't want to enroll in that study and nobody wants to ethically do that study, because if we think that myomectomy and uterine fibroid embolization has a negative impact on fertility, then why would we move forward with offering it except with heavy discussion, right? So this is a very hard trial to enroll for, and therefore we only have a few hundred women who have ever been in these kinds of trials, meaning we have limited data. Next slide. So here's what the data showed. This is, again, a lot of information, and let's just focus on pregnancy rates. So the study that I had on the left side of screen is on the left here table, and the study on the right. So the pregnancy rates, you can see 50% for UAE, 78% for myomectomy, and then the second set, I gotta move my pictures here. The second set, the rates were a little bit higher for UAE, so 69%, and compared quite closely to laparoscopic uterine artery occlusion. So why am I showing you this? I'm showing you this because these were the exact same authors in both studies. And so this gives you an understanding of how different studies can come out, and not because they're not ethically done, just because we have so few women enrolled in these studies. So one study, we have about a 50% pregnancy rate with UAE. The other one, we have about a 70%. Very, very different, right? The other thing that I want to mention about these studies, they were done a while ago. And one of them, for instance, the follow-up, even if a woman was completely asymptomatic, if she had had a fibroid embolization and her fibroid, let's say it went from 12 centimeters to 6 centimeters, if it was still at the cutoff of 6 centimeters, they required that woman to enroll in a myomectomy next. So it skewed the data some. And so all that to say, these studies were done a long time ago with less information and aren't strong studies, and they're repeatedly discussed in the literature about the weakness of the studies. So we don't gain a lot of information from them. Next slide. More recently, and the only thing we have basically since then, are these studies, or the study called the FEM trial. And some of you may have heard about the FEM trial. It allowed women desiring future fertility to be enrolled in myomectomy or UAE, and they were randomized to one of those. This is the 4-year data from the FEM trial that recently came out. And what's interesting about it is, although the pregnancy rates are abysmal, and we'll talk about why I think that is, if you look, the green line is UAE and the other line is myomectomy. So UAE actually fared better, not statistically significant. And there's way too few patients in this study to, make a lot of, or take a lot of information from it with regard to fertility, but UAE actually did better. And the other thing that's interesting about it is UAE started to increase the further out from embolization that a woman goes. So there's some signal there that would be interesting to look at as time goes on. The other thing that I want to point out about the FEM trial and any trial related to fertility when it comes to these two procedures is that, as you all know, women in their 40s or as they get to their 40s have a harder time to get pregnant as it is. And then we have so few trials where we allow women who want to get pregnant to be in the trial, right? So we're in a position where we don't have a lot of good information. So what is my take on it? My take on it is that we're all over the map in terms of pregnancy rates. It's very hard to quote a pregnancy rate, but we know there are tons of successful normal pregnancies after both myomectomy and uterine fibroid embolization. And I encourage women that if they're really considering fertility and they're going after fertility, that they should take some steps in advance of any of these procedures to preserve fertility. And if their symptoms are bad enough and we have a robust discussion about it, I think it's absolutely fine to pursue either option, knowing that it may impact fertility, but leaving the fibroids behind may also impact fertility. So it's a balance, and it's part of the struggle and sort of the catch-22 of fibroids and fertility. And I'm happy to answer questions about that as we go on. We're almost there. Next slide. Okay, so what about the recovery? This is our last sort of controversial topic. I'll tell you, this is the thing I struggle with the most and did for many, many years because it is not a painful procedure during the procedure. You get some sedation for the procedure. Just like you can't feel your blood flow move right now, you can't feel this tiny catheter in your blood flow move. It's when the fibroids are essentially dying that you feel uncomfortable. And I have a very, very frank discussion and candid discussion with women about how uncomfortable that can be. And it ranges, and we see a lot of different things. So over about a 10-year span, I have developed and refined in this regimen, and it's taken from some of my wonderful colleagues around the world, bits and pieces, and then things that I really believe in and that I feel have worked. The key is getting ahead of the discomfort, and there have been some real game changers for me in my process. We used to put people on what's called a PCA, which is basically a button that you can push and give yourself this little dose of pain medicine every time you didn't feel well, but it just wasn't enough. The intent was good, but it really didn't do and get the desired outcome. And so I have a very specific regimen. You can see it here: pre-procedure, during the procedure, post-procedure, and then discharge. None of these things are required, although I'm pretty strict about the pre-procedure meds. The other things are mostly as needed, but this is what I have seen success with. I always tell women to take a week off work. I used to back in my early days, and from what I learned was, some people recover in a long weekend. That can be true, but I like women to be prepared for a week off work, knowing that each day is going to get a little better, but that it takes a while to feel back to yourself. And so I like women to know that and to be prepared for that. Next slide. This is off topic, but it is on topic of fibroids and uterine fibroid embolization. But I just wanted to point out that there's so much advocacy that's needed in this space. And again, I'm not telling you all anything you don't know. This is just one of the things that we've done in the state of Alabama to look at fibroid embolization. Obviously, very, very small print because this is from a poster that we presented. But the key is knowing that there are tons of symptomatic women, estimated at least in the state of Alabama, with fibroids, and particularly Black women, especially in a region of Alabama where there's essentially no UFE. And you can see some of the stats if you look really closely. 94% of uterine fibroid embolization procedures were performed in 2 regions in the state of Alabama, and that's that middle image there. So there's just not access to this in many, many places. We're now looking at the hysterectomy data and the myomectomy data in these same regions. And of course, those are also dismal, particularly myomectomy, which is a little bit more of a specialized procedure. The key is that there's inequity in terms of the offerings of what women are given in different regions of the country. And that's very, very elevated in the state of Alabama because there are regions in the state of Alabama that are very disparate. Next slide. So in summary, I've done a lot of talking, and I hope we can now turn over to everyone else, but and particularly Bianca. I look forward to hearing her story. The location and size, there are some truths about difficulties with certain fibroids, but the key is that you have to think about combination treatments and also get very specific about your individual fibroid because they're not all the same, even in the same category. Fertility. I think there's an overstated bias in the literature regarding fertility because of the studies that were done and how they were done long ago. And especially this notion that that UFE is inferior to myomectomy in terms of fertility rates. That I don't believe that. I believe that they both probably have some negative impact, but also some positive impact. And I believe it's a balance. Recovery, find someone who's really focused on, if you're going to move forward with uterine fibroid embolization or really any procedure for your fibroids, make sure someone's thought about what that regimen looks like afterwards too, before and after. not just while you're there for the procedure. And then finally, I think the future is in advocacy and prevention. Advocacy is already happening, but prevention, we're really just starting to understand. And I hope we'll get some sessions on that later in this What the F series, hopefully, about what it is that causes fibroids and how to prevent them. Thanks so much for all the time listening, and I'm happy to answer any questions.
All right, thank you so very much, Dr. Caridi. I have to do our commercial, which is that we did do last month some prevention research that was done by Dr. Ayman Al-Hindi out of the University of Chicago. We also did a session on fibroids and fertility, which you may want to check out. So that's all on the YouTube channel. So as I see a lot of people are making decisions. So I think this is all great information, and hopefully it will be useful to you as you work through your journey and your process. And I think that's the perfect segue, speaking of journeys and processes, to Bianca's story. So Bianca, take it away.
Hello, everyone. And I have been reading you guys' stories that you guys are writing, and I relate so heavily to what everyone is saying about the myomectomies and wanting to know about fertility, because when I was in your shoes, I was online trying to search everything and everywhere I could find, will UFE let me have another baby? It did, but I'm going to tell you my whole story because I think knowing everything that you're going through and what I went through is really what will help you make the best decision, because you have to look at the full picture of what's best for your body and what your body can endure. So I took some notes because your girl went through quite a bit. I don't want to miss anything. So fibroids have been impacting my life since I was in about 7th grade. So really, really early. I didn't know that's why I was always in so much pain every month and why my cycle was so heavy. And when I went to my doctor, they didn't even mention fibroids. They just said, here, look, take some birth control, that will fix it. For me, the birth control that I was on actually ended up making it worse, and my fibroids were just growing and growing. And not until I just kept pressing, different doctors, like this can't be right. I'm passing out on stage. I am having to cancel shows. I'm anemic. I was like, I know this isn't normal. Finally, a doctor gave me an ultrasound, and we found out that I had extremely large fibroids and a lot of them. So in 2014, I'm now 24 years old at this point. So from 7th grade to 24, I've been suffering with fibroids. I had a very successful myomectomy, but I wasn't trying to have kids. I didn't even have a boyfriend at that point in my life. So by the time I did get my life together and I found my husband, my fibroids were back. I didn't know that because this time they were back, but they were asymptomatic. So when I was pregnant, they were like, hey, you have some really large fibroids and all the hormones from your pregnancy is, making them grow at an alarming rate. And because of the size that they got to when it was time to give birth, my son could not get past the fibroids. And so they had to do an emergency C-section where they went through my myomectomy scar. So I knew that I always wanted to have more than one child. I'm now in the story of my life. I'm 31 at this point. I've always been very healthy. I've always been very active, no drinking, no smoking. So I felt like I don't want to go through that again. I do not want to be down on a bed, unable to walk upright with a pillow on my stomach for a while. I said, there has to be something else I can do to get these fibroids out of me so I can potentially have a VBAC, which is a vaginal birth after cesarean. So I was just kind of taking my time because I didn't want to rush into another major surgery, which myomectomy is a pretty big surgery. And I was trying to figure out what I could do to preserve my uterus, because everyone kept telling me you either get a myomectomy again or you get a hysterectomy. Those are your choices. And I just felt like that can't be. And then I stumbled upon the White Dress Project, and they were mentioning this thing called UFE. And I was like, what is this glorious idea? It seemed to be like the thing I was looking for. So I started researching what UFE was. And as she said there's really not that much information out there about fertility in regards to getting a UFE. Yeah, so I was like, you know what? Let me sit on this, talk to my husband about it, milling it around. I didn't know anyone who had gotten a UFE, so there was no one I could call or talk to. I did ask on social media, but no one had even heard of it. So, I also had my baby who was about 1 at the time, and I was still nursing him. So I was also thinking, like, I need something where I can heal pretty quickly because I have to keep up with my son who's starting to run around. So that brings me to also, because of the large fibroids, the symptoms came back, and I was kind of like, don't want to be dealing with passing out again and canceling shows. But in 2021, I saw a commercial for the USA Fibroid Center that had accepted pretty much all insurances. They have nationwide centers. And that was another thing I was concerned about, like, how would I afford this? Will insurance cover this? And I feel like that's another thing that's often left out of this conversation, that even people with Medicaid, they can also, if this is affecting your life so badly, you can get help. There is ways to get financing to take care of this. You don't have to suffer. So I made a consultation appointment with the doctor. I asked my questions to see if I would be a good candidate. He made me go get an ultrasound right then and there so he could see what was going on. He looked at the ultrasound and told me I would be a good candidate, that he believes I would be able to conceive a child. I was in good health, and based on the fact that I had a myomectomy and a C-section, that it would just make sense for me to try this before getting another myomectomy and then maybe another C-section. That's a lot. That's a lot to be cut through. Again, I did ask him also, because I was breastfeeding, would it be a safe procedure to do if you're nursing? He said yes. And I was like, what about the pain medications? Is that going to be safe too? I was trying to cover all my bases. And he also said that we could make sure I'm on pain meds that would be safe for if you're nursing. So if any of that is something that you are going through, there are safe options for that as well. So I felt comfortable with the doctor. I felt that, and that's important. It is very important that you are talking to a doctor you feel comfortable with, that you trust. Always advocate for yourself. But I felt he was very informative. He had done the procedure thousands of times. I definitely Googled him. And he did answer all my questions that I had and answered them to said things to me that I didn't even know I needed to know. So I was like, let's sign me up. Let's make this thing happen. And then, so let's fast forward to procedure day. So I was not allowed to eat or drink anything after midnight the day before, which is, pretty standard when you're getting a procedure done. They checked my blood pressure, my heart rate. They took a urine sample. They put the IV in me and gave me pain meds before the procedure, because, it can get a little dicey afterwards. So then it really didn't take that long, and they didn't put me all the way out. I was just kind of, like she said, sedated and really relaxed. I think I kind of just was tired and took a little nap. And then when I woke up, I felt okay, because I think it was the pain meds. I was a little uncomfortable, but I also have a really high pain tolerance. I know this about myself. And then I tried to stand up, so they monitor you for a while to make sure that you're good. So then when I tried to stand up to go, I started throwing up because I just was so nauseous. I could not move without throwing up. So then they gave me some medication for my nausea, but I couldn't even keep that down. So that was an interesting ride home. You do have to have someone drive you. You will not be able to drive yourself. So then when I get home, I'm really just taking it easy. I'm laying down, doing my best to not move. A very intense cramping. I would say the first 2 days was really, I'm not going to sugarcoat it, girl, you're going to be in pain. It was very, very uncomfortable, but each day, like she said, does get better. I would say I felt like, you know, uncomfortable, but I could start moving around day 4. I felt like day 4 was where I was like, okay, we're over it. We're over the hump. And then it just gets better and better from there on out. I was back to about 100%, I'd say day 7, day 8. I went back for a 2-week follow-up, and then they scheduled a 6-month follow-up, but 5 months after the appointment, not the appointment, the procedure, I was pregnant again. So you can get pregnant after a UFE. That is very possible. I'm here. I live to tell the tale. But I do want to just put this disclaimer out there. When I went in for my ultrasounds, they did tell me that my fibroids had shrunken about 40% in size, and they were definitely not getting, you know, any blood. Like they were starting to do the pruning thing that she was talking about. They could see that on the ultrasounds. And I felt so much better after getting the procedure, like immediately. I felt just lighter. My bloating had gone down so much, like my stomach was flatter. But this pregnancy with my daughter was a high-risk pregnancy. I ended up having placenta previa and also placenta accreta because the doctors, but this is what they said to me. They said they can't say for sure, but they believe that because of the UFE, the placenta will go to wherever the most blood flow is. And because of the UFE that I got, they think that my placenta went lower down away from it, which is what caused the previa and the accreta. Again, they don't know for sure. This is what they were telling me. I just think it's fair to put this out there just so you know you can take this into consideration. Because of the placenta accreta, which just means that it was attached to my uterus as well, it resulted in a cesarean hysterectomy for me. So ultimately, I do not have my uterus anymore. I did get the 2 kids that I always wanted. My daughter was healthy the whole time. It didn't affect her. It was more me that they were worried about. Because I had 3 minor bleeds with this pregnancy, they ended up having me deliver her a month early. Again, I was okay. She was okay. I just need to put out there that I ended up getting a hysterectomy because they believe that the UFE made the placenta go lower. That does not mean that will be your story. That was my story. Everyone's story is different. And that's why it's so important for whoever your doctor is or your team is. They look at your condition. They look at what's going on in your body, and they can help you make the right choice. I think I made the right choice for me because I felt better after the UFE. I was able to have that, you know, other baby that I wanted to have, and she was healthy the whole time. Just always know the pros and cons and all the risks, and it's your choice. And, you know, you have to know what you're willing to go through and what you're willing to live with. So that is my story.
Thank you so much, Bianca, for sharing. It's something that we hope that more of us will do. I mean, you mentioned that you were looking on social media for anyone that had done UFE, and you know, it's interesting because there are so many people who have done it, and but I think that we as women a lot of times don't talk about anything that's going on below the fold, shall we say. And we just need to do more, including this very common condition of fibroids. We should be talking about it more so that it creates accountability as well. For a lot of, we've talked about, and some women have said in the chat, that doctors, you know, offer hysterectomy as the only choice. As we've heard from Dr. Caridi and Dr. Wolf's famous saying, if they tell you one choice, try a second opinion. It is really important to understand that, you know, you have various options. And there were a couple of questions that I'm going to throw back to Dr. Caridi. There was a talk about the occurrence of an infection after UFE, as well as, do you still have your period with UFE? So I'll let you answer those. And actually, I'll do a 3-fer. There was someone who asked because she has a transmural. So I know we didn't talk about transmural. So you may want to talk about that type.
Yeah. Okay. I'll start with the, let's see, the transmural. So transmural just means it spans basically the whole muscle of the fibroid. So kind of all the way from the outside to the endometrial canal, that whole part of the muscle that sits in between those, it's the whole way. So and that might not make it any bigger. It could be a 2-centimeter transmural if the uterus isn't otherwise enlarged, or it could be a 10-centimeter transmural. It's different for everyone. So it's still intramural for the most part. But so it still sits in the muscle, like we talked about, but it's just kind of spans the whole muscle of the uterus. And if Dr. Wolf wants to add anything, please feel free to, if there's any other tidbits.
No, I would say the same thing. So.
Okay. Then the second question was about infection. Infection risk is very dependent on what type of fibroids you have. In any scenario, infection risk is very low. And the issue that occurs is if someone has fibroid passage. And what happens, fibroid passage, if it's a small fibroid, a woman might not even know, especially a woman who's used to having big clots, and it can take 1, 2, or 3 cycles after uterine fibroid embolization for their symptoms to get better. So they may still be having bleeding and not even know that they passed some fibroid tissue. It's when it tries to come off as a whole and it's a big fibroid, and meaning, it's 3 to whatever centimeters. That's a different story. And it matters if they've had babies before, vaginal deliveries before, and versus if they haven't. And so that's where the risk comes in. And so I try to give an estimate, but it is very difficult to do. So I look at the size and location of the fibroid. If they have a large submucosal fibroid, I'll say, my risk estimate for you goes up quite a bit. So, if it's normally less than 1% likelihood of infection, yours is maybe 10%, and I try to base it on size and location. And sometimes percentages don't quite register in a clinic visit. So I try to always say, if there's 100 women, who have UFE and they have exactly the same fibroids as you, if you had this type of fibroid, your risk of infection is 1%. But if they have the same types of fibroids as you and yours is risky, 90 of them will go through this procedure and not have fibroid passage and infection, but 10 of them would go through this procedure and have fibroid passage and infection. And these are the signs of that. I'm going to remind you of that. If we go forward with this, I'm going to tell you right before we have the procedure, right after we have the procedure. I'm going to tell you at a week when I follow up with you. I'm going to tell you at 3 months when I follow up with you, so you know what that looks like. And so we would catch it right away, kind of thing. So it is variable, but it is low in most women. Dr. Wolf, anything to add to that one?
Yeah, and I just talk to women a lot too about just, ahead of time, do they have any, history of like recurrent pelvic infections, things like that. It's important for us to know, to share that entire history. Usually I say your pain should get better each day post-procedure. If you hit a point and that pain starts increasing, that could be a sign of infection or fibroid passage. So to let us know. Also, again, kind of a clear kind of vaginal discharge is pretty normal, but if you start to see funny odor, funny color, again, those can be signs of infection. So we just, same thing, have a big discussion ahead of time about what to watch for as well. But I agree, location is important in looking at your risk for infection. But again, and the risk overall is, like Dr. Caridi said, low, but just keeping an eye out for those symptoms.
And then question number 3 was about, I'm sorry, I forgot that one. Can you remind me?
Menstruation after, and then there was a question about, is this a procedure for women pre-menopause? So I think you can answer.
Yeah, both of those are great questions. So let's talk about the menstrual cycle. So menstrual cycle does remain. And there are rare instances where a woman stops having a menstrual cycle. And that usually happens in women who are perimenopausal to begin with. And often where I've seen it is if a woman's already having irregular cycles due to the perimenopausal period, where she'll come and she'll have a horrible cycle and then won't have a cycle for 3 months and then have another horrible cycle, and then it might go 4 months or that kind of thing. And we always talk about, when they have that pattern to begin with, maybe you don't need to do anything. Maybe you're already, this is petering out, but sometimes women are so profoundly anemic or just at their wits' end. There's a variety of different reasons why a woman might decide to go ahead and pursue something, but we do throw the option on the table that maybe you're already perimenopausal and this is actually going to stop on its own as long as it's not life-threatening. But it really is a woman's choice. So menstrual cycles should stay, and they stay in the vast majority of women. And in fact, that's a good thing because that goes back to sort of the fertility and there's a lot of things that play in here. Again, there are some women who come to me and they're like, oh gosh, I don't want to cycle afterwards. And I'm like, but there are other women who want fertility afterwards, and we want to make sure we're not affecting your hormone levels, right? And some of the more recent studies that have come out have showed that the hormone levels are not affected significantly different than in other procedures related to fibroids. And so that's a good thing for the most part. And those having those hormones is purposeful in for a lot of things in the body. So yes, you keep your menstrual cycle. Women who don't want a menstrual cycle, again, there's options for a combination treatment. So there's something called endometrial ablation, which is essentially, really graphically, it's just kind of the frying of the lining of that endometrium that sheds every month. It's a pretty simple procedure. The downfall to endometrial ablation is it doesn't treat the fibroids themselves. So if you only have bleeding and you're in your late 40s or early 50s, that might be a reasonable thing to do because it'll stop the bleeding. But if you have fibroids that continue to grow, or you already have bulk symptoms, then it doesn't address that issue. So another opportunity for collaboration. Some women come and they get a uterine fibroid embolization and they do really well, but they really just don't want a menstrual cycle at all. They've got now lighter menstrual cycles, but they're ready to be done, 6 months down the road or whatever. There's no reason that they can't have an endometrial ablation as well. It just, again, doesn't treat the fibroids. So collaborative can be helpful there. And then question, I'm going to go to the chat here just to see what I'm missing. Yep. So in terms of menopause, so this is really a procedure for premenopausal women. If a fibroid is growing in the postmenopausal state, that would be a sign of a worrisome fibroid. It doesn't always mean it's actually a worrisome fibroid, but it's atypical to have a fibroid grow in the postmenopausal state. All that said, the reason why some women just around the time of menopause, right before it in that perimenopausal state, why I don't discourage a woman from having a fibroid embolization is because what we do to the fibroids in fibroid embolization is what the body does naturally in menopause, but it doesn't happen quickly. So when we cause that prune to happen, your body does that essentially over time. The fibroids kind of shrink and become calcified, but it takes years for that to happen after menopause. And so there are some women who have bulk symptoms after menopause. They no longer bleed, but their bulk symptoms are driving them crazy. And I, in rare instances, in collaboration with a gynecologist and looking at all possibilities and taking everything into account, we have decided in a few cases to treat postmenopausal women. Very unique circumstances. It's not the norm, and it involves a lot of discussion and imaging follow-up and things to be sure that we're doing the right thing for the patient. I hope that answers those questions. Let's see if there's anything else in the chat.
Yeah, I know we're hitting the end of our time, so if you want to answer in the chat, please do.
Okay.
You can bring it up. I know that we had a couple more things just to talk about some of our survey from last year. There were some interesting points related to UFE. So Rochelle, you want to cover those? Oh, you muted yourself. I think it doubled.
I'm muted telling you that you're muted.
Sorry about that. So, this first slide here just kind of shows, when we did our survey last year, that there are a lot of treatment options when it comes to uterine fibroids. So again, even though we talked specifically about UFE today, this just showed the different types of treatment the women who took the survey had, where in our population, myomectomy was the most common procedure performed for the respondents in the survey who did have a treatment. Uterine fibroid embolization was a little bit, lower than both hysterectomy and even just some medical management. But again, not to talk really about specifics, but just kind of illustrating again that there are multiple different options out there, and some women in our survey had not undergone treatment yet. Next slide.
So I'm going to ask you before you move on, just because we did talk about, Dr. Caridi talked about endometrial ablation, and then there's the other types of ablation that we're familiar with. So if you want to just talk about that distinction really quickly.
So yeah, so sometimes people hear about the word ablation. So like Dr. Caridi talked about, there's one that's called endometrial ablation that doesn't treat the fibroids, just treats the lining of the uterus. But there are more newer treatments out there. People may hear the words Acessa or Sonata, and those actually use radiofrequency ablation, or what's on here as myolysis, where either laparoscopically or through the cervix, hysteroscopically, a gynecologist can go in and essentially put a small little needle or probe into the fibroid and use heat to kind of, again, shrink that fibroid. So it's similar to uterine fibroid embolization, but it's not a global treatment. And they're not cutting anything out, but they're just using heat to decrease that fibroid size. And then do you want me to talk about the other things on the list, or those are kind of the...
No, you could go on to the survey.
Okay. Yeah. Yep, sorry. So next slide. So then again, too, we were just looking at, you know, why people kind of chose the treatment that they chose, kind of what were some of the most important aspects that were like extremely important, moderately important, or not important at all. And again, you know, the most common thing was, you know, due to the severe symptoms. And then when we looked at even just taking care of the heavy menstrual bleeding, I don't have the slide up there, but when we looked at symptoms overall in the respondents in our survey who had a diagnosis of fibroids, it was close to almost 50% of people who had fibroids did have heavy bleeding as their symptom. So again, there's a lot of different reasons for people to undergo treatment and choosing the treatment option that is best for them. And so, you know, you'll hear this again several times, that really it is a discussion with your preferences, the treatment options out there, and kind of the indications to choose one or the other. So really good conversation with your healthcare provider to talk and kind of tailor your treatment specifically to you.
And I think that takes us to our conclusion, which hopefully I saw someone in the chat. This did help you with your decision if you're in the decision-making process. This is your being proactive when you're coming to these sessions and really doing something. You're learning, you're getting information. And as was mentioned, this can be combined. You know, you don't have to wait, especially because, you know, Rochelle and I look at these treatments. There's, of course, lifestyle things you can do. Check out the YouTube on prevention. There's, you know, there are various medical management. Some people have been talking about Orion and some of the other, there's other pharmaceuticals that you actually can be given that can help with symptoms, again, and they may cause some limited shrinkage, but they're really about treating your symptoms. And then you get into things like UFE, which we sort of classify in this sort of non-invasive. It's really just that pinprick. And then you come to minimally invasive, and then there's the open surgical. So there's such a range of options. You know, just continue to educate yourself on the treatments, but make sure that you are taking care of yourself in the process, because as they grow, the treatment options shrink. So it's an inverse relationship. And there are, you know, repercussions to the growth. But going back to what Dr. Caridi said, it is all dependent on, someone asked about big and small. It's really relative based on your body. We've talked about it. Bianca said it. Rochelle always says that everyone's a snowflake. So you've got the different curves or the different, you know, points on your snowflake. So be sure to support one another. Tell a friend. If you're getting the one treatment only response, consider getting a second opinion. And we've talked about this time and time again. Within the relevant information from a fibroid treatment perspective of what might work for you is going to be dependent on really a lot of factors, but particularly the type and location. We talked about FIGO classification. So really know your numbers, basically in terms of sizes, know your types, and where your fibroids are, so that as you're reading through things, particularly if you go into research, you know, you can really have a good understanding of where you're coming from in terms of what treatments could work for you. So I wanted to make sure you know the next session that we're having is in July because it's Fibroid Awareness Month, yay! And we've opened it up. It's Ask Research. So we may or may not have the answer in the next session, which is, oh, Rochelle, check me. I think it's July 7th, I think. It's the week before the conference. We want you to bring your questions, and we will, you know, if you send them through the Eventbrite ahead of time, we can try to make sure that we're going to have a host of folks that will be at the empowerment experience. So I don't know if Dr. Caridi, if she's going to be joining us, but maybe she will because she'll be at the experience. So we want to just really continue to have this dialogue because that's really what's going to help. So again, you could always email us at research@thewhitedressproject.org with questions, with requests for us to do a what the F on it so you can get the latest and greatest in terms of research. I want to thank so much, because this is volunteer, Dr. Caridi and Bianca for taking their time to share this wonderful information with us, because this is how we really help one another. And this is why you're going to go out and each one teach one and tell people about it if they're interested in UFE. So no longer will we have Biancas who are looking on social media for something, because we're going to put this out there in the world. All right, and with that, I think we can call this one done. Yeah, I think everybody wants Dr. Caridi or Dr. Wolf to move to their area of the world so they can do their procedure. So thank you, everyone. Stay tuned for the July one. We'll be sending out the recording within the next week. So we'll be available if you want to review something, or you want to take a look at a slide again. And thank you for attending.
Thank you, everyone.
Thank you for having us.
Thank you. Have a great night.
Bye.